Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing health care to the residents of the Washington Township Healthcare District for the past 60 years.
Hello, welcome to today's presentation, Shoulder Pain, Causes and Treatment Plans, presented by Dr. Russell Nord, Orthopedic Surgeon and Washington Township Medical Foundation and Medical Director of Washington Sports Medicine. Dr. Nord is a board-certified orthopedic surgeon and sports medicine physician who treats a variety of conditions in both athletes and non-athletes, but he has a special interest in the shoulder. In addition to proudly treating our local community and many of our local high school athletes, Dr. Nord also has experience treating many collegiate and professional athletes. Dr. Nord completed his sports medicine fellowship at Stanford University and his orthopedic surgery residency at NYU Hospital for Joint Disease in New York City, where he was selected executive chief resident during his final year. Dr. Nord received his MD degree with honors from Cornell University and completed his undergraduate work at Duke University, graduating summa cum laude. Please welcome Dr. Nord.
Thank you very much for that kind introduction, and thank you to everyone for tuning in this afternoon for what I hope will be a very interesting talk. And of course, thank you to Washington Hospital Healthcare System for hosting this event. Okay, so getting right into it, we tried to make the title as clear as it could be and just get to the meat of the issue. It's why does my shoulder hurt and why is it not working properly? And then of course, what can we do about it? Okay. So before we get into too many details, why don't we start with a brief outline of what we're going to talk about. The shoulder is a complex joint, and it's going to be difficult to understand what can go wrong and what we can do about it if we don't understand what the shoulder is, what makes it up, and what its anatomy is like. So we'll go over that in details. Once you understand that, you'll see that sometimes the shoulder can be too loose, sometimes it can be too tight, structures in the shoulder can become inflamed or torn, and sometimes the shoulder can become arthritic, which is what we call it when the shoulder becomes worn out. So to look at this in more medical terms, once again, we'll do an introduction with anatomy, and then we're going to go over some things which we call shoulder instability and shoulder dislocation. That's when the shoulder is too loose. We're going to talk then about frozen shoulder, which is when the shoulder is too tight. We're going to talk about AC, or acromioclavicular joint pain, which is pain you get at the end of your collarbone at a little joint there. It's also the joint that can be injured when someone, quote unquote, separates their shoulder. Then we're going to get into a very important part of the talk, which deals with the rotator cuff. A lot of us have heard about the rotator cuff. What the rotator cuff is a series of tendons and muscles around the shoulder, and those can be inflamed, i.e. tendinitis, or sometimes they can be torn, and there are various treatments for either of those scenarios. We'll also talk about the biceps tendon, which sits right in the front of the shoulder and can be a source of pain. And at the end of the talk, we'll discuss when a shoulder gets worn out with shoulder arthritis and touch on a special case of the cause of shoulder arthritis called cuff tear arthropathy, which is when the rotator cuff is not working and you get arthritis as a result of that. So, obviously I'm preaching to the choir. Everyone here has an interest in shoulder issues. That's why you've all tuned in, and we thank you for that. But it's a very common and costly problem across this country. If you look at all of the musculoskeletal complaints that someone comes to the office with, 16% of them deal with the shoulder. When you look at everything that walks into a primary care doctor's office, not just things that deal with the musculoskeletal system, there's still 15 episodes per 1,000 that have to do with the shoulder. Over the course of anyone's life, 70% of us will deal with shoulder pain at one point, and some recent data suggested that at any one time, 1 in 4 adults is dealing with some level of shoulder discomfort. This is also a very costly problem. These are old numbers from 2000. I imagine the dollar figure is much higher now with inflation and such. But the treatment of shoulder dysfunction in the U.S. is a significant cost burden, with over $7 billion spent on it in 2000 alone. Okay, so let's talk anatomy a little bit. As everyone can realize, the shoulder is quite a remarkable joint in terms of the range of motion that it's able to go through. You can raise it all the way up over your head. You can go behind your back. That's unlike other joints in the body. The reason that it can do that is because although it's a ball and socket joint, as you see here, the socket is very small. It's very shallow. So it's more like a golf ball and a golf tee, okay? Now, because of this, because the socket doesn't have intrinsic stability in and of itself, we rely a lot on soft tissues to stabilize and power the shoulder. And we're going to talk about that in just a minute. So this here is a picture of the shoulder. This little cartoon over here is kind of what we looked at before in the x-ray. It just shows the bones. You have the ball here. You have the socket here. The ball is called the humeral head. It's part of the humerus, which is the arm bone here. You have the socket, which is called the glenoid, but it's part of the scapula, the whole shoulder blade. The end of it actually has the socket on it. And then there are other bones ahead. There's the collarbone, or clavicle as we call it. At the end of it is the AC joint. And then there's the acromion, which is actually another part of this scapula that curves around over to here. And the area in between is the acromioclavicular joint, or AC joint for short. So I said that the soft tissues were important, and they are. Let's look at them here. So if we had the shoulder joint here, we kind of cut around it and then opened it up. What you'd be doing is staring down at the socket. That's the glenoid there. There's a little cartilage ring around it called the labrum, which will be important when we talk about shoulder instability. The biceps tendon, which I alluded to once already, comes off of that and then runs down the front of the shoulder. There's a capsule that holds the ball and socket together. It's been cut through for this diagram, and that can be too loose or too tight. Beyond that, there are a number of muscles, 4 of which are the rotator cuff muscles and tendons. You see them listed here. The subscapularis is in the front. The supraspinatus, which is the most common one that becomes a problem in humans, is up here on top. And then as you go in the back, you have the infraspinatus and the teres minor. Above that, above the supraspinatus specifically, there's a bursa called the subacromial bursa, and sometimes you can get a bursitis where that gets inflamed via a process called impingement. So we'll talk about all that, but hopefully this gives you a good anatomical roadmap. So all this will be clear. Since the rotator cuff is so important, let's just look at that a little more clearly here. This is looking from the front. This is looking from the back. In the front, you have this main muscle called the subscapularis. It is very important. And then when you look up top and from the back, you see the main rotator cuff player, the supraspinatus here. Going below that, you have the infraspinatus and teres minor. And you see these muscles all attach onto the humerus. So what can go wrong? Well, a lot of things can go wrong. And anything can go wrong at any age. So the only rule is that there are no rules. However, often the things that typically go wrong are dependent and related to the age of the patient. So you can kind of track that over time. And any of these structures we talked about can have a problem and fail, and that can lead to a variety of different problems. And that's figuring that out is what we call diagnosis. Once we make a diagnosis, or diagnose a patient as we call it, then we can figure out what the best treatment is because we've put a name to this problem. So that's basically the process we go through. So this is basically our roadmap for the talk today. You can see here, we start with someone being younger. We end at the end of the talk with someone being older, this imaginary patient we're talking about. Younger patients tend to have more of an issue with instability and dislocation, but that can happen to older patients too. Middle-aged patients tend to get this frozen shoulder and AC joint pain, but it can happen in younger or older patients. Rotator cuff tendinitis and tears tend to happen about the same time, but again, there are no rules. And shoulder arthritis often happens in older folks, but we see it in younger people too, especially if they've had a lot of dislocations and destroyed their joint there, which is a difficult problem. All right, so without further ado, why don't we get into it, starting with instability and dislocation. So, dislocation is when the shoulder comes out of the socket all at once. You're fine 1 minute, and you're very much not fine the next. What you see here is a gentleman who has a shoulder dislocation on his right side, which you see here. This is a normal looking shoulder, which we're all used to seeing. Even just looking with the eyes here without an x-ray, you can tell something's amiss here. And what's going on here is that the shoulder's been pulled down into the front and it's dislocated out the front of the shoulder. This can happen from a variety of methods, sometimes torquing the arm behind you. So this is what an x-ray might look like in that setting. You can see the ball's no longer centered on the socket. It's sitting down, and if you took an x-ray from the other side, in this case, you would see that it's out the front. It can also go out the back sometimes, which we call posterior. Here's a cartoon showing this similar situation. It should be up here, but sometimes it's not, and that's a problem. When that happens, common sense rules the day. We want to put it back in place, and that can be done by a physician in a healthcare setting. Sometimes patients will actually figure out a way to put it back on their own, especially if they're out in the woods somewhere or something like that. Once you get it back in place, we typically put the patient in a sling for about 3 to 4 weeks, and that should allow the shoulder to stiffen up a bit and tighten up and become stable again. However, in younger patients, often this is not effective, and there are recurrence rates for another dislocation even if they've been in the sling for 3 to 4 weeks. The range for this is quite varied and quite wide, as you see here, but the numbers are much higher if someone's under 20 than if they're my age, here, over 40. So if someone's over 40 and they have a first-time dislocation, we're pretty confident they can do well in the sling, assuming they haven't torn anything else like the rotator cuff. But if they're under 20, we start thinking, maybe this is going to be a recurrent problem just due to your age, and maybe we need to think about some other options. If we're thinking about something like doing surgery, we might get something called an MRI, or a special type of MRI that has contrast injected into the joint. That's called an MR arthrogram. That's what we're looking at here. This is a slice through a shoulder, okay, basically like this. You have the ball here and the socket here, and that little labrum, remember that goes around the socket? Here in the back, posteriorly, it looks great. Socket right into labrum, doing wonderfully. You look in the front, not so good. The labrum is floating off in the middle of nowhere, and there's a tear where it's torn off the socket. That's a Bankart lesion, also known as an anterior or front labral lesion, and this is typically what happens when you dislocate your shoulder out the front. You tear the capsule, you tear the labrum, and that can be a problem. Interestingly, we talked about the subscapularis, just as an aside. Here it is here, one of the rotator cuff tendons, and it looks fantastic in that MRI picture. So, sometimes folks need surgery. Here's another cartoon showing this labrum torn off the front bottom portion of the glenoid. I'm using these terms on purpose. And in some patients, surgery is a good option here. Surgeries can typically be done arthroscopically now, which means they're done through small incisions with small instruments and such. And what you can see is that we can put these little tacks called anchors in the socket below the surface of the cartilage, and little sutures come out, and we can snug up the capsule and labrum tissue and create that little bumper, that little connection that the shoulder needs to be stable again, and make it so there's less room for the shoulder to slide out. Now, the risk of re-injury still exists, but it's a very effective treatment for most folks. Here's an example of that. This is looking inside the shoulder of a 15-year-old water player that we took care of. And this is the socket, the glenoid. Here's the ball hiding up top here. And when you're looking in the front here, it's just openness. It looks like the abyss of space here. It's a little bit of tissue here, flimsy, not looking so happy. The labrum's totally missing. It was scarred down actually below deck, like hiding under here, if you will, in the background. After freeing this up and elevating it and putting some anchors in and then tying knots, you see some of them over here, the stitches are blue, we recreated that labrum and the capsule and the bumper, and this is much, much better for this patient, and this patient got back to water polo, which is a pretty vigorous sport for the shoulder, and did very nicely. So that's just an example of the Bankart repair, which we can do for folks. Now, not everyone who has shoulder instability has that immediate dislocation. For a lot of folks, it's more of a chronic issue, and they might not even know that shoulder instability is their problem. This we often call multidirectional instability. It's most common in the young. There's really no trauma that's necessary. Sometimes there's a little bit, sometimes it's not even clear. The patient just notices some pain, they're not functioning as well, they come to the doctor not sure what the issue is, and maybe the doctor figures out that it's instability, and the patient really had no idea. There are some predisposing factors to this. Sometimes just repetitive microtrauma, as we call it, which is just loading the shoulder in extreme positions over and over again, such as things that was like swimming and weightlifting in certain positions, volleyball, gymnastics, pitching in baseball. That can lead to this sort of issue. Also, some folks are just built very, very loose, like this contortionist over here, and if you're built that way, you're certainly going to be predisposed to this. Now, what we're going to see in a minute here is sometimes these risk factors kind of converge. Here's Michael Phelps, quite a swimmer there. I know he has long arms, but even if my arms were as long as his, I wouldn't be able to do that. My arms simply aren't stretchy enough. Excuse me. Additionally, thank you. Additionally, we see another Olympian over here, and she's actually able to put her arm in very unusual positions as well. Also something I wouldn't be able to do. So these folks here, they obviously became Olympians for a number of reasons, but one of the reasons they were likely able to become an Olympic swimmer is because they have more shoulder motion. That aids in swimming somewhat. And then by swimming a lot, it stretches the shoulder more. So they're totally set up for having the shoulder micro-instability issue. They protect themselves against that by being incredibly strong. And just like the shoulder has multiple layers like we talked about, if the capsule's loose and you're prone to this instability, you can strengthen the muscles around it. And then that'll create some stability for the shoulder. It'll act as a stabilizing force. And that's how these folks are able to kind of walk that fine line and have looser shoulders but still be strong and still be functional. Contortionists also, like I said, have this sort of challenge, if you will. So what do we do? What does this look like? A normal shoulder joint should have some looseness to it and some ability to stretch, and you see the little extra pouch here has a little extra room, but when you have multidirectional instability, the pouch is too big. And we're going to see this contrasted in a little bit when we look at frozen shoulder, also known as adhesive capsulitis. And in that case, this pouch is all shrunken up and too small. Here you see the biceps tendon, by the way, just out of interest. So that's multidirectional instability. And what do? Typically, we rehab. We rest and we strengthen, just like we talked about, to get those rotator cuff muscles and other muscles around the shoulder stronger to help stabilize the shoulder. And if that doesn't work, we do it again and again. But sometimes that doesn't actually work. Even though we've been very patient and tried multiple rounds of physical therapy, some patients have an issue, and I actually have someone that is going to need surgery for this in the very near future. So what we can do in this case is we can tighten up the capsule. We can make it smaller. In the older days, this was typically done through an open incision. We'd literally make little T incisions and bring the capsule over itself and tie it down snug like this. But nowadays, this can typically be done fairly well arthroscopically by passing little sutures through different parts of the shoulder, tying them snug and kind of bunching up the capsule. And often we'll put little anchors in like we did for the Bankart repair and kind of snug up down here as well. And the rehab's pretty similar to someone who had that Bankart repair from the dislocation. Typically, folks do very well. 85% of individuals are able to do what's called RTP, or return to play, get back to the sport that they want to be doing. Okay, so that's phase one of the talk, if you will. Let's get on to phase two, the next point in our timeline, which talks a little bit about frozen shoulder and a little bit about AC joint pain. We'll start with frozen shoulder. This is a very common condition. It's something I see in my office literally every day. You get a stiff, painful shoulder. It's slowly progressive. Patients have a hard time identifying when it started. It kind of just comes on, and then eventually it's really bad, and they say, oh, I got to do something about it. It's kind of like they got cooked like a frog. They don't really know when it started. All of a sudden, it's a problem. Anyone can get it, but it's more common in women, and particularly those aged 40 to 60, and particularly those with diabetes, with thyroid issues. Some other issues also, like kidney and heart problems, can predispose, but anyone can get it. Diabetes is the main one. We see it very, very commonly in diabetics. The x-rays and the MRIs usually look normal, other than maybe seeing a smaller little capsule, which you see here. Here's a normal capsule on another cartoon, nice and happy and not red and nice and loose. Here, it's red, it's inflamed, it's shrunken up, and the volume goes down from about 30 milliliters to only 10 milliliters. And what that means is when you try to move your shoulder, you run out of room, you run out of room, you run out of room, you can't do anything. And the shoulder becomes very stiff and it becomes very painful initially. And patients eventually come to the doctor to seek medical care and treatment. So typically the treatment starts with stretching, physical therapy, home exercises. Often we'll do a cortisone injection into the ball and socket to try to decrease the inflammation and pain. And then if that's not working, and it's been 6 months or so, we'll often do a manipulation under anesthesia where we put the patient to bed and literally stretch the shoulder out and break up that scar tissue and then get them right into rehab, and they try to maintain that. Sometimes we'll do a surgery to actually break up the tissue from the inside and take care of other issues in the shoulder. Often, frozen shoulder will take care of itself and resolve, but it can take up to 2 years, and it doesn't always lead to full shoulder motion, so sometimes people do require some assistance. All right, moving on to the AC joint. There are a variety of conditions we're going to talk about that relate to the AC joint, or the acromioclavicular joint. The first one is arthritis. This is more common in overhead athletes and laborers. It's commonly starting in the middle age, so people my age typically have signs of this on their x-ray. The initial treatment doesn't involve surgery. We say avoid the things that hurt it. Maybe you can do a cortisone injection right in that AC joint, which we see here on this x-ray. And if that doesn't work, we can trim off the end of the collarbone. So you can basically go in with the small incisions and the camera and the little devices and trim away a bit of collarbone so it creates more space at that joint so it's not rubbing up against itself and causing pain. This here is an x-ray, like I said, of a normal AC joint. Here's another one that's arthritic. You see how there's a lot less space between the two bones, the acromion and the clavicle. There's some spurring, it's more white, and this is something that we often see. One of the keys here is to realize that not everyone with an x-ray that looks like this actually is having pain from this. This is very common on an x-ray, but you have to examine the patient, talk to them, make sure this is actually the source of the pain before you start trimming off the end of their collarbone and doing injections and such. So that's where the whole picture comes together with taking a history, which means talking to the patient, doing the physical exam, and looking at the imaging. We have to put all that together. It's all very important. All right. There's kind of a variant of that, which is called distal clavicle osteolysis, which happens often in younger patients that are big weightlifters. And the end of the collarbone almost just seems to melt away. You see here, you can hardly see it on the x-ray there. And the treatment's exactly the same. Avoid the activities, try an injection, trim off the end of the collarbone, but it's kind of a different condition. It's worth just mentioning briefly. So, we talked about a separated shoulder before, and that's what we're going to talk about now. This is the trauma, the accident to the AC joint, okay? Now, the shoulder is the glenohumeral joint, the ball and socket that we've been talking about before with instability. But when we talk about the acromioclavicular joint, that's the collarbone, once again, with the acromion. And the reason the collarbone stays lined up with the acromion is because there are some ligaments that sit here that hold it down, and there's some ligaments in a capsule here at the AC joint that hold it together. And if you land on your shoulder hard enough, you can tear all those. Often a quarterback will get this if they get driven into the turf after a sack or something like that. And we'll show you a picture in a minute of one of these separated shoulders right here. So starting at the bottom here, you can see that something is amiss. This looks like a nice, happy left shoulder, and indeed it is. And something's wrong here. The collarbone is just sticking up right under the skin. And this is what an x-ray might look like. When you measure the distances between these two parts of the bone, we put these little red lines here. This is a normal distance. This one is much more. What's happened is the collarbone has gone up a bit, and the rest of it's just fallen down because it's lost the suspension from here. If this is very mild, then often this can be treated without surgery. But if it's more severe, we often end up reconstructing it. The x-rays you were looking at would likely be one we'd recommend reconstruction for unless someone was very old or infirmed or not very dependent on the arm. If we treat them without surgery, you just stay in a sling, we rehab them, we give it some time, and hopefully these ligaments that have been torn, the corticoclavicular ligaments and the acromioclavicular ligaments and joint capsule, will kind of scar down, and the patient will become functional and do well. And a lot of patients do well without surgery for that. But if it's like one of those severe cases, what we can do is make a little incision, weave a tendon graft around this bone here called the coracoid, which is part of the shoulder blade or scapula again, and then fix that to the collarbone in a variety of ways, use some suture as well in different ways, and secure that, bring the collarbone down, and give it excellent stability. And patients actually do very well after this kind of surgery. All right, now we're moving on to the meat of the talk here. Rotator cuff tendonitis and tear, probably the most well-known issue that befalls a shoulder. All right, so is it the star of the show? Probably, but I think all these conditions are important. I have no favorites. So as we said before, the rotator cuff is a series of 4 muscles and tendons that go around the shoulder. Here's another nice picture of it. There's the subscapularis, but the main troublemaker here is that supraspinatus. I know the names are long, but that's the way medicine is. And you got this bursa up here, and then you have these other rotator cuff muscles around the back. So these stabilize the joint, as we talked about when we talked about instability, and of course they're muscles. They always also move the shoulder joint. The way joints and bones move in our bodies, you have a muscle, which you see here in red, and it can contract, kind of squeeze tight, and then it magically kind of transitions to a tendon, which is the white area over here. There's a transition zone here called the musculotendinous junction, and then the tendon is really robust, and that attaches to a bone, and it pulls it. Very mechanical, all right? That's how they work all over our body. So rotator cuff issues commonly affect the middle-aged, as we see. Sometimes someone can be fine 1 minute, they have a fall, maybe they tense up and they pull off this tendon all at once, maybe with a piece of bone, maybe without. That's an acute injury. More commonly, though, we see with just overuse, or not even overuse, just a chronic issue that they don't know why it started, but it just did. They're just doing their normal activities of life, and all of a sudden they had pain, and the doctor said they had a rotator cuff problem. So what clues us in that it might be the rotator cuff? one of the things that we often see and hear about, excuse me again, thank you, is pain at night. A lot of these individuals with rotator cuff problems describe they have pain at night, they have trouble sleeping, they can't find an easy position to go to bed. We're not sure exactly why that is. We think it might be because you don't have gravity pulling the arm down anymore and it kind of wants to ride up and do that impingement and irritate the bursa and such. Also, perhaps just your mind is clear and you're not bothered by other things, so you think about your shoulder pain. No one really knows. But they often have pain laterally out here. Lateral means to the side. So even though the rotator cuff sits up here, they tend to have pain over here. And this red muscle is not the rotator cuff. This red muscle shown here is the deltoid. And the reason we think that is the case is because when your rotator cuff, especially the supraspinatus, is not working well, the deltoid has to go into overdrive and compensate for it. And your deltoid muscle begins to ache and it inserts, it attaches right over here. Okay, so that'd be something right over here. So a lot of these rotator cuff people say, oh, my arm's killing me right over here. And I say, well, this sounds like it might be a rotator cuff in your shoulder. And they say, but it's not my shoulder, it's my arm. I say, we'll look at your arm too, but I have a feeling it's actually kind of tricking us that it's the rotator cuff and the deltoid is causing some pain here as well, but really it's the rotator cuff that's at the root of it. And we can do tests to discern whether it's just a deltoid issue, which is very uncommon, or a rotator cuff issue, which is very common. All right. So these folks often describe difficulty with reaching, difficulty reaching behind the back or overhead, and they can be very, very disabled by this. One of the key distinctions we make, and this was an important slide I thought to bring in, is could it be the neck? The cervical spine, right here, is just near the shoulder, and there's a muscle called the trapezius, okay, or the trap as many of us call it, which connects the two essentially. The trapezius is this kind of triangular muscle here, which I'm outlining with the cursor. It starts up at the cervical spine over here and flares out and actually attaches to part of the scapula. This is the back of the scapula over here, the top of it, and then comes down and attaches to the back over here in the spine. So this here can cause a lot of pain, and people will sometimes say, oh, my shoulder's killing me right over here. And we say, well, let's examine your neck. This could be your neck. So that's an important thing to figure out and tease out so we don't start treating the wrong area. The complicating factor, it's never that simple in medicine. The complicating factor is if your shoulder is causing trouble, sometimes your shoulder blade is kind of out of whack and out of position for a variety of issues. And that can secondarily pull on your trapezius and cause secondary trapezial issues. So sometimes trapezial spasm and issues there will coexist with shoulder pain, which may actually be the primary issue. So that's one of the important things we try to tease out so we can give the best treatment. But back to rotator cuff. The most the least severe of the rotator cuff kind of issues on the continuum would be considered the itises, okay, bursitis, tendinitis, something that's inflamed. Often this happens as a result of what's called impingement, which is pinching that you can get. Here's the ball, here's the socket, here's the acromion, here's the bursa. When you move your arm in certain positions, the acromion can pinch down on that bursa and on the rotator cuff tendon itself. Okay, that's impingement there. All right, certain acromions have different shapes, and the ones that are more hooked, like you see over here, are more likely to cause this pinching. Now, if someone has that, we usually try to treat them non-operatively. This is a theme for much of what we're going to talk about today. We try rehabilitation, we try physical therapy, anti-inflammatories, by mouth. Oftentimes we'll do a cortisone injection. These don't hurt much at all. They hurt less than a flu shot, I always tell folks, and I think it's true. And this can go into the bursa and help decrease the inflammation and pain here. So even if they have anatomy that predisposes them to the pinching and activities that predispose them, to the pinching, if we can clear out the inflammation there, it kind of deletes the situation, they get a fresh start. And this anatomy that they've had since they were 18 years old and had been working well for them for, pick a number, 40 years, hopefully they'll start behaving again and not causing trouble. But that's not always the case. Sometimes patients say, that injection was fantastic, thanks doc, but it only lasted 2 months. And we say, okay, well, that's not really long term. So what we can do in that case is we can go in surgically, once again, small incisions, clear out the bursa, make sure the rotator cuff looks good. Patients would be getting x-rays and MRIs before this. And we can trim up the acromion. This previously had a spur here, and it can raise the roof, if you will, and create more space and clearance. And it's typically very effective. Going back to the continuum that I alluded to earlier, this is the tendinitis, sometimes called tendinosis, because it's less of an inflammation and more of just a degenerative breakdown. So we've had some terminology evolution over the years. But this should be nice and clean and white on this cartoon, and it's kind of wavy and red, and that's how the artist depicts it. A pretty good depiction, actually. If it gets a little more severe than that, you can get partial tearing, okay? Here you see that part of the rotator cuff is peeled off, the underside, which we call the articular side, because it's on the joint side, which articulates. And it could also happen on the bursal side, which is the top side, and that would be more from the impingement. And these partial thickness tears often can be managed non-operatively, but sometimes they turn into full thickness tears. Now you can see the whole thing is pulled off, and it's actually retracted a bit. We'll talk about this in greater detail in the coming slides here. So, like I said, we're going to get x-rays, we're going to get MRIs on these individuals. The x-rays may show these large spurs. This is a very extreme example here. Sometimes we get surprised and we see this calcium deposit. It's actually sitting inside the tendon itself. This is called calcific tendinitis. These folks come in miserable. All of a sudden, they're in terrible pain. They usually do very, very well with a cortisone injection. If they're not getting better, like I said, we get an MRI. It might show some partial thickness tearing like this. Looks just like the slide from before, right? Where you have this little white spot. This is the rotator cuff tendon coming in here above the socket and the ball, and it should be attaching on this part of the humeral head called the greater tuberosity. But this white spot is a tear, and it's an articular sided tear, just like we saw in the other cartoon. And here, we have the other shoulder shown here, but it's pulled off all the way and actually pulled back probably about 1.5 centimeters or so here, okay? This will likely continue to pull back more with time, because remember, the muscle's over here and it's pulling. So there's no way this is going to go back and land over there. It's going to keep pulling back more, and in most cases, it gets bigger and bigger. I always tell folks that once this happens, it's kind of like, imagine if you had a tent pulled really tight with some stakes, or a tent fly perhaps, and then you pulled up one of the stakes and the tent, boop, comes back a little bit. There's no way it's going to go back to the ground. It's being pulled the other way. It's just going to put more tension and more stress on the adjacent tent stakes and put pressure on them and predispose them to failing as well. And that's how rotator cuff tears get bigger over time. We'll talk about that more in a little bit too. So, not all rotator cuff tears are treated the same, because not all rotator cuff tears are the same. Someone might say, I got into a car accident, and this is a legitimate car accident, nothing to turn your nose up at, but cosmetic damage easily fixed. It's difficult to even look at a picture like this, but there are other car accidents which are very different. And just like this analogy here, some rotator cuff tears are partial, right? Articular on the undersurface, bursal on the top, interstitial is kind of in the middle on the inside itself. And there's complete tears. But not all complete tears are like this. There's little ones, there's medium ones, there's large ones, and there's massive ones. Some are really not pulled back at all. Maybe they just happen from a fall and you catch them early and can tack them down even though they're huge. Other ones maybe have been going on for years, kind of neglected, and they're way pulled back. And those are harder to fix, because when the muscle is attached to a tendon and the tendon's not attached to anything anymore, the muscle's not getting any exercise. It's just pulling on the breeze, not doing anything. And what that means is that the muscle will actually start to turn to fat. That's called atrophy. And when that occurs, it's no longer stretchy. All right? You can't just pull it with all your might and get it back to where it's supposed to go. It'll start to tear, and that won't work well. So here's some examples of that. These are different shapes of rotator cuff tears. Here's the ball. These are looking kind of from above, from the skybox, the VIP section at one of the stadiums. And you see that the tendon pulled back. And you basically, I find these surgeries really, really fun, because one of the things you get to do when you go in is you try to understand what the geometry of the tear is. Is it pulled straight back? Is it pulled to one side, pulled to another side? Is there an extra little tear going somewhere? And you have to rebuild it in the correct steps, in the correct way, to get it to be balanced and attached properly. So we always alter techniques. Every rotator cuff tear is a little bit different, and every rotator cuff repair is a little bit different, so that keeps it interesting and fun. Here's an example of retraction, a little bit retracted, no big deal. Here, still very repairable. If one was like this, pulled back a little bit, but we should be able to work with that. This one's really pulled back. It's all the way to the glenoid. The tendon's kind of gone at this point. It's degenerated. You're just dealing with muscle, and that muscle's all atrophied. This, you're not going to be able to repair. There's other ways we can treat that. One of the ways is through something called a reverse total shoulder replacement, which we'll talk about at the end of the lecture, but we'll get to that in a little bit. All right, so who needs surgery? Not every rotator cuff tear requires surgery. A lot of tears are asymptomatic and don't cause a lot of trouble, and a lot of folks actually have these and don't even know it and are going on just happily with their life. So just because someone has a rotator cuff tear on MRI doesn't mean they have to immediately be rushed to the operating room for surgery. These folks, we talked about the symptoms. We have to make sure it's from the rotator cuff, think about the functional demands of the patient, and see if this is a tear that's going to get worse or progress, because then it's something we might want to jump on sooner rather than later, especially in a younger patient. So we talked about these repairs. Traditionally, they were done open through larger incisions, but now we can do them through the arthroscope, through minimally invasive methods. The healing process, though, even with a small incision, it still takes a long time. Shoulder surgeries typically have fairly long recoveries overall. They're typically highly effective, but the patient has got to, no pun intended, be patient, because things take time and it's a stepwise process. What you can see here is that there was a tear, stitches were put through, here's another tear there, eventually it gets socked down here. I'll show you some pictures from a specific case. This is a cadaver. This is not a patient of mine, of course, but this is an excellent surgical dissection or anatomic dissection that someone did of a cadaver, and it shows the different rotator cuff tendons here. Okay, so this, the subscapularis over here, supraspinatus over here, infraspinatus teres minor over there. This lady, we're going to show you, had a tear that kind of went in this kind of wiggly fashion, like so. It was pulled back like that, and you see this over here. Here's the arc of the tendon, the rotator cuff pulled back. It should be all the way over here. Now this one, you don't want to just pull straight over. That's not how it's meant to be. This is one that actually you have to zip back up over here, and then you can tack it down. All right, you can tell this by feeling it and looking at it, evaluating the MRI. So the first thing, thank you there. First thing we did is put a few stitches in to zip it up. And that we did over here. Now the tear looks very manageable. Put an anchor in over here, have some stitches coming out, tie those down over here, and then those stitches get passed to another anchor farther out to the side, and it kind of socks it down like a cargo net, and we've got a very happy rotator cuff there that, given enough time and rehab, should serve the patient well. Little bonus talk on the biceps here. About half of the rotator cuff repairs I do also end up with some sort of treatment for the biceps, usually a reattachment. The biceps is called the biceps because there's two attachments, like bicycle, two wheels. The attachment that always gives us trouble is this one, the long head. This is the one we looked at in the other pictures. It has this little exposed portion of tendon with no meat or muscle to protect it. It rides through this groove here, and over time, it just often gets irritated after cycle. And if folks have rotator cuff issues, but they also are saying they have pain in the front here, or maybe just pain in the front, and they're tender over their biceps when we push on it, and it doesn't look good on the MRI, then it tells us that we should be doing something with this. So this can be inflamed, and it can be problematic, and they have pain with lifting. So what can we do? Once again, same theme. Sometimes anti-inflammatories, PT, cortisone injection. Sometimes you can just release the tendon, cut it. You still have another attachment, and patients can do well with that. Brett Favre and John Elway both won Super Bowls after their biceps tendon either was released surgically or tore on its own, and they did very well with that. But most of my patients, we choose to reattach the tendon, as it has some advantages we'll talk about. One of the disadvantages of just releasing the biceps is you get this deformity here, cosmetically. This is called a Popeye deformity, which you'll see here. All right, aptly named. The biceps goes south for the winter, not in all cases, but in many. And while the cosmetics might not be an issue for many folks, oftentimes they get some aching or, kind of bad feelings in the biceps muscle because it's not at the right tension anymore. So that can be an issue. As a result, what we can do is just make one little extra incision down here and tack down the biceps right here to the arm bone, the humerus, and then remove this section over here. And then we have a nicely tensioned biceps, and the muscle doesn't know whether it's anchored here or up here. So it's happy. We just got to let it rehab and recover and such. And you bypass this groove here that was causing all the trouble because nothing's in it anymore. All right, the last hurrah here, shoulder arthritis. We're on to the older patients now. So this is a big issue in the U.S. Not as common as knee and hip arthritis as a complaint, but it's a major issue, and over 40 million people are affected in one form or another in the U.S. The loss of the articular joint cartilage is significant, and it can be degenerative wear and tear arthritis, inflammatory arthritis like a rheumatoid arthritis, and there can also be arthritis due to the rotator cuff and such. And the 40 million people, I think that's arthritis overall. All right, so shoulder arthritis progression. This is an x-ray that doesn't have any arthritis in it. This is a normal appearing x-ray. Here, you have some narrowing of the joint. So this is some early progression of arthritis. We see this, we say, something's going on. This loss of motion, the popping and pain you're describing, I think it's due to some early arthritis. This is maybe a 0 out of 10. This is a 2 out of 10. All of a sudden, this is what a 10 out of 10 would look like. This is terrible shoulder arthritis. You can hardly see where the ball ends and the socket begins. It's got this big bone spur here. The bone's all white from being overstressed. These are the folks that end up with surgery for their shoulder arthritis. However, not everyone needs surgery, of course, and some of these folks have different symptoms. They often describe these items up front like pain, stiffness, and swelling. When they move the shoulder, or you move it for them, it literally can sound like Rice Krispies. They'll move their arm and it'll be pop, 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 pop. And that's just that really arthritic 10 out of 10 shoulder just moving because it's no longer smooth anymore. The x-ray is very helpful here because someone might come in, if they don't have the Rice Krispies finding there, and the shoulder's stiff and painful. You don't know if it's frozen shoulder or arthritis. But if you get the x-ray and it's normal, frozen shoulder. If you get the x-ray and it looks like that other one we looked at, well, then you know it's arthritis. And we can figure that out just in a few minutes. So we try the non-operative treatments, same collection of them that we've talked about before, medicines, injections, therapy. But if that doesn't work, there are different options. If someone's very young, maybe we don't want to do a shoulder replacement on them because they don't last forever. We might try to just clean up the shoulder via one of those arthroscopies, remove some bone spurs, etc., buy you some time, even though it's not forever. They might need a shoulder replacement eventually. There are partial shoulder replacements. Those are less commonly done, but there's still a role for that. It's called hemiarthroplasty. Just replace the ball or part of the ball. Then there's a total shoulder replacement where you replace the ball and socket. And there's something called a reverse total shoulder replacement where we'll talk about in a minute. You actually put the socket where the ball was and the ball where the socket was. And this is something that allows a shoulder replacement to work even if you don't have a good rotator cuff. Whereas by contrast, if you do a regular total shoulder and you don't have a good rotator cuff up here to keep the ball down and center it on the socket, it'll ride up and eventually loosen the socket and it won't work well. It'll have a problem. The reverse shoulder replacements are actually more commonly done now than the regular ones. We'll talk about that a little more. Here's a regular shoulder replacement. You can see it kind of looks like what the shoulder used to be. You have a stem here to hold it in place, although it can be done without a stem nowadays. A little metal ball that supports and recreates the head that was removed. And then on the socket side, the glenoid, you can't see it on x-ray because it's made of plastic, but you get a little socket cemented in. And that rides along very happily. And patients typically do well, assuming the rotator cuff is very reliable. However, let's say you don't have that. Let's say you have a patient with or without arthritis, but they have massive, irreparable rotator cuff tears. Or you have a patient with arthritis and their rotator cuff just doesn't look that reliable. Maybe it's got some early tearing, not enough that you'd say it needed a repair, but you're not sure it's going to last the next couple of decades for them. And they're also older. Maybe they're over 70, and you say, you know what? One surgery, they'd be one and done. Let's do a reverse total shoulder. We don't have to rely on that rotator cuff. If it fails later, they'll be protected by that. The reason this works so well is that it's a more constrained joint, so it's less likely to ride up, and also to do some interesting physics that have to do with the lever arm of the deltoid muscle. You're able to generate more torque with the same force through an increased lever arm, for those of you who like physics, with this setup of a shoulder than the one that we're born with. So by reversing it and putting the socket on the ball here and a ball jutting out from the socket here, you end up with a deltoid that can function through a longer lever arm, and it can generate more torque and cover for a supraspinatus and rotator cuff that aren't working well. And this is an excellent option for older patients. So this is a cartoon of what that looks like. You see the socket is where the ball used to be, and we've screwed in, that's how we do it, a ball onto the socket after repairing it appropriately. Here's an x-ray. These patients typically do very well, and the use and popularity are increasing. There are a number of reasons to do this nowadays. The recovery is actually easier than a rotator cuff repair, but if someone's rotator cuff can be repaired, and that's always my preference, because that is keeping their own anatomy, and you always have this as a bailout if they have a problem in the future. So you don't want to jump to this, even though it's sometimes appealing. But if their rotator cuff can be repaired, that's the way to do it. So that's basically the scoop. That's a lot to chew on. There's a lot of good technology out there. And with that, hopefully you've got a little introduction to the shoulder and how it works and what can go wrong. And we're happy to entertain any questions if any came in.
Thank you, Dr. Nord. We do have some questions. One of them that you just talked about. What is the estimated length of time for recovery after a shoulder replacement, and what are the limitations?
Very good question. Well, it differs a bit for reverse total shoulder replacement and regular total shoulder replacement. But for either of them, you're pretty much limited to a sling for the first 6 weeks or so and just doing some very kind of supervised exercises under the direction of a physical therapist. For reverse total shoulder replacement, you don't want to have the shoulder and ball and socket pop out, because like a hip replacement can do that. Reverse total shoulder replacements can as well, and you want to let that shoulder scar down a bit before you stress it too much. So we have the sling for that purpose. For the regular total shoulder replacement, we have to protect the rotator cuff, specifically the subscapularis in this case, and that you have to move through and work through to get to the shoulder. We have to let that heal before we stress the shoulder too much. But then after that, for the reverse total shoulder replacement, you kind of progress almost as able to, just not forcefully pushing the shoulder in any one direction. And the regular shoulder replacement, you just work on your strengthening as you can and your stretching, and you typically recover pretty quickly. For a rotator cuff repair, it often takes a good 4 months to be able to even start strengthening. For the shoulder replacements, it's sooner than that. And for the rotator cuff repair, it's usually about 6 months for someone really to feel like they're fully recovered, although we have super men and super women who are, come in at 3 months and they're looking fantastic. Everyone's a little different. But for the reverse shoulder replacement, oftentimes, by 2-3 months, patients are doing super well, and the total shoulder replacements also recover more quickly, just a touch slower than the reverses, I would say.
Okay, another question. How often and for how long can cortisone shots be used to treat shoulder pain?
Good question. There's no specific rule. Most physicians have a guideline that they wouldn't want to do a cortisone injection in a joint any more frequently than every 3 months. However, cortisone injections, we've learned, are actually more deleterious. They have more of a negative impact on the rotator cuff than we thought even a few years ago. So for example, when I started practice here 12, 13 years ago, the standard thinking was if someone has a rotator cuff tear, a small one, what have you, try a cortisone injection first, see if that helps. What we've learned since then is that if you do a cortisone injection prior to, say, a rotator cuff repair, the results on that rotator cuff repair aren't as good, even if the cortisone injection was given up to a year before that surgery. I try to avoid any cortisone for a minimum of 4 months before any rotator cuff repairs. But there's different parts of the shoulder. AC joint injections are more like joint injections. You can kind of give those more regularly. And if you do that multiple times for a patient, kind of the worst outcome you could get is degeneration of the cartilage in the AC joint, which they already have. That's why they're getting the injections. And eventually, maybe they'll say, just trim off the end of my collarbone. You're really not setting yourself up for a problem. Same thing too if someone has glenohumeral joint arthritis, ball and socket arthritis. If they come back multiple times and want injections and they're working for a while, that's reasonable. It does contact the rotator cuff there, but if you're not worried about the rotator cuff, that's okay. But for the rotator cuff specific issues, the cortisone injections are in my opinion, less of an optimal option than they used to be.
Another question, last one, is I like to lift weights, but my shoulder hurts with certain movements. Is there anything I can do?
Well, lifting weights is interesting. So basically, there's certain positions that you can put the shoulder in that are more stressful. If you go to the extremes of motion, all right? So one of the things we say, we joke around, we say, first date rules in the weight room, basically. Keep your hands where I can see them. Don't put your arms all the way back. Don't put them behind your head. Military press is not good for anybody, okay? That's a difficult shoulder position to be in. So this is one of the activity modification things we talk about. If someone says my shoulder only hurts, when I'm, reaching for my, hedge clippers, which are up on the top shelf of my garage and I can't get them. Well, rather than do some extensive shoulder surgery for you, maybe move the hedge clippers. And if it only hurts when you're clipping your hedges, maybe get someone to help you with that. Same thing with the weight room. If someone's having trouble with a couple certain exercises in the weight room, just avoid those. And in general, try to keep your arm in the more favorable positions. Don't do butterflies way out to the side. Avoid the military press. Lat pull downs behind the head. Those can be problematic as well. And just try to keep it more in front of you. You can still get an excellent workout, and that should help your shoulder tolerate the challenges in the weight room.
Okay. Thank you, Dr. Nord, for this insightful presentation. This concludes our program. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.
Excellent. Well, thank you very much. Once again, thanks to Washington Hospital for hosting. Thanks to everyone for tuning in. Thanks to everyone on the production team. And I hope you all have a great day and learn something. Stay well.